Hello, everyone. My name is Simon Bogdanovich. I am the Chief Business Development Officer at Liquiditi Solutions. I'm here based in sunny Los Angeles, California. I want to thank everyone for being on with us here today. So giving you a quick background on Liquiditi Solutions. Really, the company is founded to help combat COVID-19 and offer critical support to governments and private enterprises by really streamlining the process of acquiring life-saving medical supplies and equipment. And we've developed, through our suppliers and manufacturers, integrated testing, tracking, and health passport, digital health solutions so that governments as well as businesses can reopen their economies in a safe and a secure way. So our mission as Liquiditi Solutions is to protect humanity from the catastrophic events of the pandemic with safety equipment, testing, and solutions that span the globe. Thank you. And now I will pass it off to Alice, who will get us into the first session of the forum. Thank you.
Hi, everyone. My name is Alice Litkova, and I'm your co-host today. I would like to first and foremost thank Liquiditi Solutions and Unit Ventures for inviting me today. A little bit about me is I'm an author, journalist, and a spokesperson for fintech companies. As a media personality, I have launched a show called New Economies at NASDAQ and the London Stock Exchange for the purposes to advocate for more women in technology and specifically blockchain technologies and cryptocurrencies. A lot of the people in the industry have pivoted to the healthcare sector, specifically looking at solving the supply chain issues. It's really great to see someone like Simon from the fintech industry and I co-hosting now this event and pivoting into the healthcare space. I'm based in California and I travel across Europe and the United States. So I would with that being said, I would like to introduce to you the first panel, which is called Present and Future of COVID-19 Testing, Treatment, and Prevention. In this session, you will hear from medical doctors and researchers who are leading COVID-19 initiatives. John, who will be your moderator, will lead this panel. John?
Hi, everyone, and welcome to this first session of today's forum, which aims to give you more of a medical and a scientific perspective on COVID-19 and the pandemic. So my name is John Leon, and I'm coming to you today from Boston, Massachusetts as your moderator. I myself am a medical researcher at Harvard University with a background in infectious disease research. And in my past research, I've been certified to work with airborne pathogens in a biosafety level containment setting. And I've also been involved in the development of novel vaccines. I'm joined today by three panelists, Dr. Dara Kass from New York City, Dr. Chenwei Wu from Seattle, Washington, and Dr. Bridget Queenan from Cambridge, Massachusetts. So if I may, I'd like each of the panelists to introduce themselves. And if we could, let's start with Dr. Kass.
Oh, hi. My name is Dr. Dara Kass. I am an emergency medicine doctor in New York City at Columbia University Medical Center. I also am a person who had coronavirus. Some people use the term survivor, but I think I'm just recovered. I had it early on in March, where I recovered in about a week and a half at home. So I think we'll talk about that a lot. And I've been advocating for kind of widespread testing and tracking since the beginning and communicating straight to the public, mostly related to the lack of federal leadership on testing, tracking, and PPE procurement. So I think that this is going to come up a lot over the next half hour.
Let's go Dr. Queenan next, please.
Hi, everyone. Yeah, I'm Dr. Bridget Queenan. I currently run a biology research center at Harvard, Boston, and have spent the last 20 years in and around various aspects of biological science, engineering, and technology, making drugs, devices, educational materials, building research centers, and I'm currently involved in a few efforts to get those COVID test kits made and distributed, as we've been hearing so much about.
And Dr. Wu.
Hey, good morning, everyone. So I'm Chen Wu. I graduated from Harvard as an undergrad, went to Duke for med school, and then graduated residency here at the University of Washington. I'm currently an internist working as an inpatient doctor in the Seattle area. I'll leave the affiliation kind of out of it, so just here as a private citizen, but have not caught COVID, have taken care of a couple of COVID patients, and just recently we did look over our case records for the hospital, so should have some background there.
Yeah, so thank you all for being here today. And before we begin, I just wanted to make clear to our audience that what you hear in this session are the opinions of the panelists themselves, and our views don't represent the institutions that we work for or belong to, so please keep that in mind. And also during this conversation, if there are any questions that you have, please feel free to type them in the chat box or to message me directly, and we'll try to address them if possible. So yeah, let's get this show on the road. If I may, I'll start with Dr. Wu. So you're based in Seattle, Washington, and Washington State was the first state in the United States to report cases of COVID-19. So could you share with us what that initial response in the state was like, and what are some of your personal experiences from treating COVID patients during that time, and how are things going now?
Yeah, sure. So, so interestingly, I was actually in Chile when all this blew up. So left at the end of February for the last vacation in a while, and was down there and kind of just scrolling through the news. And that's when the Life Center skilled nursing home cases erupted. So left, everything was normal. We were saying that this is not here, even though we had that case up in Everett originally. Went back and kind of was very hypervigilant about anyone coughing on the airplane on the way back. And got there, and the whole hospital had been reconfigured. So entrances closed off, flow metered, that sort of thing, testing in place to the extent that they could. So there was a lot of physical plant changes that was there. And kind of from that point on, it was sort of getting trained in personal protective equipment use, which there are fits and starts to that. But I think that did ultimately get smoothed out. And then waiting for this surge, because Seattle, we were kind of in the lead going up that curve. So interestingly enough, as the cases were hitting around the city, mostly in the suburbs, we were just waiting for it to hit our hospital. And that actually never happened. So it stayed mostly in different hotspots around the city. So again, very geographically isolated pockets of intensity. So we were watching that hospital resource prediction, the IHME forecast from the University of Washington, that group. And April 15th or something was our predicted peak day, and we were just getting ready for that surge. And I was on service during that time and took care of one or two COVID patients, but really the surge didn't happen. A lot of folks just stayed home. So it was a very bizarre situation where you're expecting a lot of anxiety, and then the exact opposite happens. That's, again, my personal experience. I know that is like completely different in other places, but I think that just highlights how geographically, how much heterogeneity there is. Even in the city of Seattle, the downtown core was largely spared, and then it was Renton and the suburbs that really got the majority of cases. I will say, though, that I think the reason that we ducked a lot is the fear of that.
I didn't see you. I thought you were parked there. Okay, go. All right, I'm gonna go.
Was that the fear of that first nursing home? And so I think that got the community really red alert. And the consequence of that was that people were and are still a lot more vigilant. So this city has not had a problem with face masking. I go out to the grocery store and pretty much everyone is masked. And certainly if you're not wearing a mask or forget it or something, you definitely feel like there's this social expectation that you should be wearing it. And I think that's protective.
Right. Excellent. Thank you. And so Dr. Cass, I want to come to you next because you're based in New York. And so we've seen New York City become the epicenter and the focus of the pandemic here in the United States. So Can you tell us what it's been like working in New York City during this time? And what do you think the city how is it doing now in terms of providing care to patients?
So I think that New York City has been a really good example of what can happen when the people's will really does reflect the data and the science. After Seattle saw its hotspot and we saw nursing homes get overwhelmed, we kind of watched it happen on the West Coast for about a couple of days. We thought we had more time, and actually we didn't. And then we saw the travel, the international travel that was coming into New York airports was really what triggered our cases. We just didn't know it at the time, and we we very quickly, at least as quickly as you can get a whole city of 11 million people and 19 million in the state to act, got to a real database approach, which included mask wearing, getting our PPE up, really kind of increasing our vigilance around data and science. And actually the daily press briefings from our governor, I think, was really helpful for people to see both the increase in number of cases and how testing was effective, and then the decrease in the number of cases and how the work of the New Yorkers was really reflected in the health of New York City. And we really also realized the vulnerable populations of New York City, whether it was intergenerational homes or low-income people or communities of color, really having a disproportionate impact of this virus, which allowed us then to increase and focus testing in those communities as well. So in the middle of all of it, like I said, I got sick amongst almost like a lot of people that I knew. And we really learned quickly how to take care of people with the virus at home. We increased our capacity for telemedicine. We increased our capacity for testing and tracking, trying very hard to catch up with the need that was out there. And I think that now that we're on the downswing in New York City and we're opening, we opened other states and other counties in our state before New York City itself. Now we're dealing with the other side of this, which is if we are going to have a data-based approach to this virus, and if we're going to continue to open and close as a response to the, infectability of the R naught of the virus or the number of hospitalizations or ICU or anything else, how do we interact with other states that are not doing that? Right? What do we do with states that are not having the capacity to test, that are seeing a 20% positive rate, like they're seeing right now in Arizona for their testing right now? And what does it mean? And as we open in New York City, really high volume experiences like the subway system or our public school system or our airports, how do we get ahead of finding the virus as new people come in? And that's, I think, why as early as today, the governors of New York, New Jersey, and Connecticut put in a quarantine of 14 days for people traveling from hotspot states, because it's the first indication of us having to protect ourselves from the lack of, honestly, state and local leadership in other states that are not conforming to science the same way we are here.
Yeah, very interesting. Thank you. And Dr. Queenan, I wanted to spotlight you as well. So you've been involved in the Boston area with companies in developing COVID test kits. And so could you tell us about that experience from a scientific point of view and what it's been like and what kind of challenges have come up in the course of that work?
Yeah, so it's been interesting. I have come at this from both a scientific and a personal perspective. I had been down in New York in February when things were starting to explode, and had come back to Boston from New York's Chinatown with a really bad respiratory infection. And I was like, okay, don't be racist, but like, this is not great. And I had actually called up one of my friends because they're working, the company that she founded is working on making at-home molecular test kits to be like, is this flu? Is this RSV? What have you got? And I was like, can I get one of those? Because it would be really helpful right now. But we just started talking and was like, okay, we should add COVID in there, right? It would be great if people could have the peace of mind of, I'm sick, I've got a respiratory infection. It's manageable right now, but which one of these is it? And so started going from there and started, getting the data, filing the protocols, getting some of the grants. But then one of the things that's been really interesting about the process is, and I think that, this forum will be talking more about it, but people have really recognized in light of this pandemic that just the way we manufacture things has to fundamentally change, right? That some of these aspects of the global supply chain just are not going to be capable of handling pandemics and kind of climate-based disasters. So it's actually been, I think, a really exciting time where the culture has changed a little bit, that in industry, people recognize it's like, okay, if we're trying to make these molecular test kits, let's just make a bunch of different ones based on fundamentally different strategies, right? And the same thing with the vaccines, like, let's just kind of diversify and then see which one works. And I think that that's actually been really healthy, is to say, A, we don't know which of these is going to work first and which is going to work best. And B, we just don't want a bottleneck of every single one of these test kits or every single one of these vaccines requiring the same reagent that's produced in the one factory in the one place. So I am actually pretty excited about whether this, kind of changes some of the attitudes, within medicine and science and technology, to say, like, it's actually great that we're kind of dividing and conquering in some of these spaces, and that some of these test kits and some of these vaccines actually could be appropriate for different audiences. So there isn't like, oh, here's the right answer and here's the wrong answer. Like, let's just get as many answers into the right context as possible.
Yep. So thank you for that. It's really good to hear about some of your personal experiences in your respective cities. So I kind of just wanted to open up now in terms of some basic information about COVID-19. So let's start with, we've heard continuing debate that COVID-19 is similar to the flu in terms of morbidity and mortality. And I think that opinion is starting to change. But I think to the general public, in your experiences, how would you compare COVID-19 to the flu, and what differences have you seen, especially in treating patients during this time? So let's start with Dr. Cass.
Yeah, it's not the flu. This is like, I mean, I'm just going to stop that. Like, this is the analogy with the flu was put out there by people that wanted to minimize the risk because the flu is something people are comfortable with. The flu has vaccines, it's not a vaccine, right? The flu has a mortality rate that's related to, the seasonality of it, and we know a lot about how to treat it. And it's, people kind of wrap their hearts around the idea that if it was not as bad as the flu, we could be okay. It was really a comfort mechanism around people that didn't understand what we're dealing with. And it is a virus, then the flu is a virus, and that's about when you can stop. There's a lot of other viruses out there. Okay, there are muscle aches and fatigue in both of these viruses. There are muscle aches and fatigues in a lot of viruses. And then I think the other thing that I want to unpack about the flu is that a lot of conversation about this second wave in the fall that I think people are worried about, and that's the only other time the flu comes up. The virus, the coronavirus itself, like the symptoms that it presents with, are non-specific, and that's a lot of the testing issue we've had. So it's malaise, fatigue, you can lose your taste, you can be short of breath, you can have a cough, you can have a headache. Some people get nauseous and vomiting, and then obviously there's the effects on children after the fact, when in this undefined period of time they have a multi-system inflammatory condition that affects a lot of their blood vessels and their hearts and other issues. The end stage of the coronavirus for adults usually happens a lot, another inflammatory condition where they have difficulty breathing, they have heart, kidney issues, a lot of other multi-system inflammatory issues as well. We need to find the virus when people are well at home, and certainly before they get so sick that you kind of hit beyond the pendulum spot to make them better. A lot of the treatments we focused on is this hospitalization and critically ill aspect. A lot of the remdesivir and a lot of the hydroxychloroquine and a lot of these hospitalization trials have been on these very critically ill patients. But the truth is 85 to 90% of patients will not even ever go to a hospital with this virus. And so we need to figure out who they are early. We need to treat them aggressively. We need to keep them from the hospitalization, not just from a resource perspective, from a public health perspective, because once you get that sick that you need hospitalization, we actually don't know the long-term consequences of this virus on bodies. I think that and I think Bridget as well, can explain the effects you have when you have this virus after the fact. I still have shortness of breath and chest pain, and I had a mild case of the disease. This is a virus that stays with you for a period of time afterwards. The flu doesn't do that. The last thing I will say is that in the fall, when we go back inside and we're still dealing with potentially the first wave, right? We're still in the first wave. We haven't gotten it at bay. We haven't gotten it down anywhere, except for maybe New York and New Jersey and Connecticut. we will have to figure out when patients come to the ER or call their doctors with a respiratory symptom and viral illness and a fever, whether or not they have the coronavirus, because it affects their mandatory quarantine and isolation, or else we're going to be isolating everybody back again. Right? And so that's why we need rapid testing to understand. But the conversation about the flu is not that the virus acts like the flu, it's that they're both viruses, and that in the fall, we are gonna have to figure out very quickly if somebody has the coronavirus, influenza, or something else. Right. Fair enough? Sorry, that's my soapbox.
That's great. Very, very, very strong perspective, and I love it. So let's follow up with that, Dr. I wanted to ask you to respond to this. So, like what Dr. Cass was just saying, in terms of seeing a second wave, we're now in summertime, and especially with states and cities going through phase reopenings right now. What are some of the expectations that you might have for the summer? Do you predict that there will be a second wave come the fall? And what kind of advice would you give to people about how they should take precautions during the summertime?
Yeah, I think that first and second wave distinction, right? It seems like the first wave is blending into that second wave. We've all seen the curves. Maybe a place, when this getting into immunity and some of the comparisons to influenza or the next topic, which may be vaccines, is that the places who had it very severely, so a lot of folks have that herd immunity. So folks like New York City is probably one of the better spots to be, as things are progressing, because if you can compare this to a wildfire, it kind of burned out all the fuel in that tightly packed, densely populated space. And so the curve in New York is fairly flat. I think the CNN tracker was saying doubling rate every year or something like that. Whereas places that actually were successful at the beginning of this, in terms of flattening the curve, they've slowed the rate of transmission. So they've decreased the steepness of that slope, but it may not ultimately change the area under the curve in terms of the total number of folks who are going to get affected. Now, that has actually met the objective of taking the pressure off the healthcare system. So places like California, you're seeing that steady rise. It's the most populous state in the union. And it's headed back up to its rightful place in all of this. So yeah, so there is that. Is it going to come back? Has it even disappeared? I don't know. I'm treating this as maybe an eye in the storm and loading up on toilet paper and getting a haircut before things turn south again. But I am definitely concerned that things are going to get worse in the fall, just like with every respiratory virus. So we take past as a prologue, then that's likely what is going to happen. And I am more concerned now than I was 2 weeks ago, looking at that curve already starting to bend upward. And just, I think, getting back to what Dr. Cass was saying, this is a brand new pathogen that we're trying to learn what it does to the body. So I think a lot of the flu, the way that I picture it is it's the virus doing its thing. This, I think, has a lot of host factors involved. So that hyperinflammation, where a person will come in day 10 of their symptoms and just crump. So Boris Johnson was taken to hospital around day 10. We have actually admitted someone who was perfectly fine on day 10 because of concern that that's when that hyperinflammatory stage is going to take off. So, and then the clotting that happens, the multiple PEs and strokes, and this Kawasaki syndrome in children. There's so many things that this is way beyond influenza, and no one is immune, except maybe now a lot of New York. So that's kind of the situation.
Yeah, Dr. Cass.
Yeah, New York isn't immune. I want to be really clear about that. I want to be really clear that we're nowhere near herd immunity in New York City. By best efforts, we may be hitting 20% infiltration in the highest density areas of New York. There are other areas of rural New York that probably have numbers between 5 and 8%. We have to get to 70% to even remotely hit herd immunity. So the reason that the virus is at bay at New York very much has to do with the actions of New Yorkers, mask wearing and social distancing. Yes, it's true the fire is lower because there is less virus probably spreading in the air, and so people, even when they're in close contact, aren't at high risk. But like the idea of herd immunity, we'd have to lose hundreds of millions of Americans to this virus to get anywhere near natural immunity, and we still don't even know if the antibodies that I have are going to stay long enough to give me any sustained immunity in the pack. So I want to be clear that New York City is as at risk of getting this virus back as anywhere else in America. And that's something we make sure people understand when we open and tell people when they have to come back home. What's happening in Arizona and Florida is not an accident. It was entirely predictable, and it can happen anywhere else in America. And it will continue to happen even in states like Montana and Idaho, which have had hardly any cases from the very beginning. This is a lesson we need to learn from everybody. Sorry.
No, that's perfect. Thank you very much. And so just sort of coming off of what both of you have been saying in terms of, you know, getting this kind of information and understanding the truth about the virus and also about the disease. So I wonder, Dr. Queenan, from kind of a scientific perspective, you know, one of, I think, the challenges during this time is that data being published or pre-printed and being generated in the news about COVID and the coronavirus has just been so substantial that I think even for myself and my colleagues, it's been really difficult to figure out what data, what pieces are accurate and which, you know, pieces of advice we should follow. Do you have any advice about how to keep up with scientific progress? Anything that you do to sort of sift out the accurate information? And what tips might you have for the general public about how they can sort of navigate through all the information that we're bombarded by on a daily basis?
Yeah, I mean, I guess part of it is to express sympathy. It is a full-time job to keep track of this, right? I mean, it is just an onslaught of, which vaccine and which mechanism and which thing and which test case and whatever. I mean, so it's like, if you're overwhelmed by it, that's fine. I guess the thing that I would adopt is, I wouldn't end every speech with, and Carthage must be destroyed, but this kind of idea of, yes, there's things that are evolving, but there are things that are not evolving, right? Like, this is a virus, it is dangerous, we do not have it under control, right? Lots of people who do not have symptoms and will never have symptoms have this. Wear a mask, stay home, wash your hands. I mean, none of those things have changed. Like, we are still in the rising phase of a deadly pandemic. There's no indication that it's going to get better. And there are just some basic public health precautions that we can take in the meantime. And then to just say, we're working on it. Science is working on the test kits, it's working on the vaccines. You'll be the first to know if we have one at the, like, they're gonna wanna sell them to you. Like, the second that they're ready to go, you're gonna hear about it, right? But so it's just, I think the good news is people are pursuing a diversity of strategies for these different technologies, for these different vaccines, but those are not going to be magic bullets, right? Especially in this country. I mean, great, we have a vaccine, half the people aren't gonna get it, right? So it's like the vaccine isn't gonna solve the problem. I mean, so I think that we can focus on the fact that, researchers, doctors are doing what they can, but every individual member of the society can also contribute